Well, greetings, everyone, and welcome to the EKG videocast for the week of July 29th, 2013. This week is actually a very special week because this marks the 100th episode of the EKG video case series of the week or whatever. I probably ought to, at this point, come up with a more sophisticated or catchy name for this video series. But anyway, this is a special week, and so I did a Google image search looking for some type of image that would really typify the celebration of the 100th episode. And so I did a Google image search for celebrating 100 episodes, and this is what I came up with. So now, as a disclaimer, I'm not trying to endorse smoking by any means, but this was kind of humorous, and so I figured I'd post it there. Anyway, what I did want to talk about was an article, just briefly, that I saw in circulation July 2nd, 2013, written by a couple people that I don't know, but here's a name that I know and probably many of you have heard before, Galen Wagner. Now, Galen Wagner is one of the true cardiologist EKG gurus that are out there, and he is the current main editor or author of the Marriott textbook. And so when I saw his name on this, I thought, well, this is going to be a great article, really endorsing electrocardiography. And so I started reading. And as I got through the first couple of paragraphs, I started becoming very dismayed because it started talking about the EKG at the crossroads. Now, generally speaking, anytime someone or something is at a crossroads, it's never good, right? And the first couple of paragraphs validated that concept. It talked about the mythology of electrocardiography and how old EKGs are and all this new technology that's been coming out. And I started thinking, gosh, maybe it's time for me to come up with a new hobby instead of electrocardiography. Maybe, I've always wanted to take up the ukulele. Maybe I better start taking up ukulele. Well, I'm not very good. So I decided to keep reading. And anyway, as I read further into this article, I kind of got the gist of what Dr. Wagner and his colleagues were trying to say. And this article is a really nice, quick read. It's only a couple of pages. It really talks about how, as medicine has advanced, people have really gotten into high-tech stuff, expensive stuff, glitzy stuff. Even the electrophysiologists, who are supposed to be probably the torch bearers for electrocardiography, have really moved more into high-tech stuff. And electrocardiography, which is often considered a relatively basic skill, has kind of gotten left behind. And they make the point that a lot of younger people in emergency medicine, well, they really talk about cardiologists, but a lot of younger people in medicine who look at the EKG are really just focused on looking for a STEMI. And if they don't see STEMI, they don't really care that much about what's on that EKG. They just rely on what the EKG interpretation says. Not only that, but the EKG interpretation algorithms, the computer programs that read EKGs for you, are not even up to date with the most recent advances and the most recent criteria. So it's really disappointing to see them talk about the reality, but in the end, they really made the point that we need to get back to learning this very relatively basic skill. And I'm going to use the term basic in quotes here. Okay, basic. Because even though this may be a basic technology or simple technology, it saves lives. And I've really tried to convey that over the past 99 episodes, that if you have a little bit more than basic skills, you will save lives. And just for fun, I went back through the past 99 episodes and came up with some interesting things. These are some of the things that we've talked about over the past year and a half, a little more than a year and a half, which, if you know more than the basics, you'll save lives. We'll start with this one. We talked about left bundle branch block and acute MI. Many of us learned the basics that when somebody's got a left bundle, you cannot diagnose acute MI. And if you know a little bit more than the basics, you know that's not true. This patient has ST depression in V3, which means this patient is having a STEMI equivalent. If you miss this, the patient's got a worse outcome. Here's another one. This patient was my patient, actually, first year out of residency. And I looked at this, and I was working at a hospital that had no cath lab, but no problem. This was a no-brainer septal STEMI. So what did I do? I gave the patient thrombolytics and admitted the patient to the intensive care unit. Well, 12 hours later, the patient's in cardiogenic shock, and very soon after that ended up dying. And had I known back then what I know now, I would never have wasted time with giving this patient lytics, because what I know now is more than the basics. What I know now is that this patient actually has ST elevation in AVR and AVL, which means this patient has left main coronary artery occlusion, which means lytics are not going to work. This patient actually needs to go as quickly as possible for cath. If all you know is the basics, though, you're going to let this patient die. That's what happened in this case with me. This is another one of my patients, another one of my screw-ups. I was under the impression, when I knew and learned the basics, that PR depression always equals pericarditis. And here's a beautiful example. You could not draw better PR depression than what you're seeing in all of these leads, right? So I looked at this, the computer looked at this, the cardiologist looked at this. All of us called this acute pericarditis because of that beautiful PR depression. And it turned out that this patient was actually having an acute coronary syndrome and started out with a troponin of 15, which was rising. This patient went to the cath lab. Unfortunately, didn't have a horrendous outcome, but we all assume that PR depression equals pericarditis, and we know that that is not true now. But if you know the basics only, you're going to miss that. Here's another one. This EKG was called normal by the emergency physician and the computer, and the final interpretation by the cardiologist called normal. But if you know a little bit more than the basics, you recognize that this flip T wave in AVL predicted that this patient was in the midst of an inferior wall STEMI. Here's another one. If all you know is the basics, you might know about Wellens, right? Flipped or biphasic T waves, V2, V3, also out in V4. So if you know maybe just a little bit more than the basics, you'd look at this and say, well, this person's got Wellens. If you know a little bit more than that, however, you know that this is not Wellens. This is actually nothing more than a normal variant. Give this patient Motrin, send him home. We talked about that before. Here's another one. This is a miss, this 30-year-old guy who presented to the emergency department with a near syncopal episode. The final interpretation was LVH and old lateral STEMI. Well, there's two problems with that interpretation. First of all, in somebody under the age of 45, you don't use the EKG to diagnose LVH, number one. Number two, why would a 30-year-old have an old lateral MI? These are not infarction Q waves. And, well, if all you know is the basics, you're going to miss this. And that's what happened. This patient got sent out and 2 days later came back to the emergency department where I saw him in cardiac arrest. I pronounced him dead from hypertrophic cardiomyopathy. And if somebody had known more than the basics when he first presented, he'd still be alive today. Here's another one. This was my screw-up again. I'm happy to share my screw-ups, learn from my mistakes. Here's a 54-year-old woman who presented to the emergency department with shortness of breath. She had a history of breast cancer, so this is a no-brainer PE, right? This patient needs heparin right away. And admit her. Maybe get a CT just to confirm it. Well, that's what I did. I started her off on heparin, and about an hour later, she was in pericardial tamponade from hemorrhagic tamponade. And that's because back then I didn't know that the combination of low voltage plus tachycardia equals pericardial effusion. She had a met to her pericardium and was bleeding into her pericardium, and my heparin nearly sealed her fate. But I didn't know about this combination, tachycardia plus low voltage back then. Now I know more than the basics, and I won't make that mistake again. Here's an arrhythmia. Take a look at the computer interpretation. AFib. It's irregular, and there's kind of a rotten baseline in there. So what happened with this patient? The patient got started on heparin for AFib, new onset AFib. The patient got admitted to the hospital. And the first night had a massive lower GI bleed, ended up having a stormy course in the hospital, had to be transfused a couple of units, fortunately survived, and the patient ended up not having AFib. And if you know more than the basics, you know this cannot be AFib because there are clumps. This was never AFib to start with. This is simply Mobitz conduction. The patient has no indication for heparin in the first place. Iatrogenic near kill because somebody only knew the basics and only looked at the EKG computer interpretation. Here's a regular wide complex tachycardia. The rate is 115. What does that mean? It means it cannot be ventricular tachycardia. You don't diagnose VTAC when the rate's under 120. Unfortunately, this patient who was in the CCU was misdiagnosed as ventricular tachycardia, got amiodarone, and dead. Here's another one, all right? Here's another wide complex tachycardia, irregularly irregular. Morphologies are varying, and that means this must be AFib with WPW. The treating physicians said, you know what? When in doubt, give amiodarone to everything that's wide. The patient got amiodarone and went right into ventricular fibrillation. Nearly died, again, because they didn't recognize something that was a little bit beyond the basics. Here's a patient with a long QT. QTC is 549 milliseconds. We talked about this a while ago, and the patient kept going in and out of Torsade. So what do you do with Torsade? Well, you try to shock him. Well, this patient was going in and out of Torsade, and so by the time they got the paddles ready, the patient was out of it, and they couldn't shock the patient. But what's the next treatment you're going to use? Magnesium, right? So the patient gets some magnesium, and it does nothing. Then some more magnesium, does nothing. More magnesium, does nothing. And the reason magnesium is not working is because this patient has a diagnostic finding that tells you that this patient's treatment of choice is actually calcium. What is that diagnostic finding? There's a long ST segment. We talked about that. And when you see a long QT, primarily due to an increased ST segment, that's hypocalcemia. And the Torsade didn't stop until the patient got calcium. Piece of cake if you know a little bit more than the basics, right? So coming back to this article, electrocardiogram at a crossroads. Is it at a crossroads? Well, I suppose you can make the argument that the EKG is at a crossroads because so many people are focused on high-tech stuff. But you know what? If you know the basics and a little bit more, you will save lives. And one of the things that I always try to preach is a very simple concept that just because electrocardiography is a basic skill, that doesn't mean that we should relegate ourselves to having basic skills. You need to be the expert with electrocardiography. You can't rely on anybody else. You can't rely on your computer. The interpretations and algorithms are flawed. You can't rely on the people upstairs because they're more focused on stents and high-tech stuff. You've got to be the expert. And if you are the expert in electrocardiography, you will save lives. And I'll argue this over and over and over. The EKG, in my opinion, is the best, fastest, safest, and most important test in emergency medicine and perhaps in medicine in general. It's a piece of paper and ink. You can't get any cheaper than that. I don't care what they charge for it, but in terms of the cost, it's practically nothing. And it's rapid, reliable, reproducible, can be done at the bedside no matter how sick your patient is. And if you know more than just the basics, you will save lives over and over and over. And after all, that's why we all went into medicine in the first place. Not to treat low back pain or chlamydia or in Baltimore, acute percocetopenia, right? We went into medicine because we wanted to save lives. And if you get good, really good at electrocardiography just through practice, you are going to save lives. And if you're not good at it, patients are going to die. This is a great skill to get good at, and that's what our past 99 episodes have been all about, and that's what the next 100 episodes will be all about also. My thanks, my most sincere thanks to everybody who has sent so many cases over the past year and a half, cases from all over the world. There's no way we could be learning without the help of each other, and so, I toast every single one of you for sending those cases. Please keep them coming. Please share your interesting cases. And if there's anything that I can do to help with this skill, with this life-saving skill, please let me know. And I actually learn a lot from the cases that you send me, so you're helping me a lot also. My thanks once again to everybody for these 100 episodes, and I look forward to staying in touch with all of you. Share this with your friends, get more people involved, and as a group, we can make this specialty and all of our specialties better and better and save more and more lives simply with a piece of paper and ink called an EKG. Thanks, everyone, and I'll talk to you next week.